Okay, good evening. Before I start today's class, I would like to go for synopsis of part one. That is the class taken yesterday. After PS1, everybody says there has to be a tutorial before you go for PS2. So similarly here, I've already shared the synopsis, but let me quickly recapture that so that today's class will have a good ground. WHO Labour Care Guide 2020 is a replacement for WHO Partograph 2011 and 12. It's just a A4 size paper tool used to monitor and document labor events. It can be used in any setup. That's the beauty of it, from third world to first world, from primary to tertiary care center, in low as well as high risk primary or multi. What more? It can be used from first to third stage. If you all recall, the old Partograph didn't have second stage entry at all. Forget the third stage. About 26 new recommendations have been added to existing 30 based on evidence available so far. So it's an evidence-based labor care guide. All for positive, this is the word that I was yesterday trying to impress upon, and respectful labor and childbirth experience by mother, child, and family, all the three, to avoid unnecessary, unscientific interventions which do not benefit the mother or child. And major change, this is very, very important for all of us, is that active phase starts at 5 centimeter. The old Partograph started at 4 centimeters. In between, Zhang's Partograph came which said 6 centimeter. He even said that 6 is new 4 and all that. So WHO made a bargain, neither 4 nor 6. It has started at 5 centimeters. This is the major change. And the other major noteworthy deviation is that getting rid of that alert line and action line, which were based on cervical dilatation. Instead of that alert line and action line, clear alerts or what is called reference thresholds have been given for each labor event observation, which I'm going to explain today. And the presumption that cervix dilates at the rate of 1 centimeter per hour in primary and 1.5 centimeter per hour in multi is given up, and a more realistic 12 hours, that is almost double. If it was 1 centimeter per hour, we were giving only 6 hours in the active phase, because active phase started at 4 centimeters and thereafter 1 centimeter per hour means 6 hours. But here it is more realistic, 12 hours after 5 centimeters and 10 hours for multi. Earlier we gave only 4 hours for multi, because we said it would dilate at the rate of 1.5 centimeters per hour and 6 centimeters would be covered in 4 hours. That's what we expected. But now they have given generous 10 hours for multi, but both of them after 5 centimeters. Also, second stage gets a generous allowance of 3 hours in primary gravida and 2 hours in multigravida. But the disclaimer is that both above, provided there is no feto-maternal distress and there is no obstetrician distress as well. And 2 sections have been added. There are totally 7 sections in the Partograph. And 2 sections have been added to monitor and document the supportive care and the shared decision. Many of you asked me, sir, is it available? Can we take a screenshot of the Partograph and all? Yes, it is available. It has not come from a brain straight away or from heavens. I have just copied the WHO label record, and I just spent some time to understand it, because first time when I read, I was not really convinced and I was not sure what are they trying to say and all that. So I said I have to crack this, and I have cracked that, and now I'm trying to make it a simplified version of it. It is available on the net. You just type WHO Labor Care Guide 2020, you will get the entire labor guide, and all my slides are based on that, even including the examples. So WHO Labor Care Guide, as I said, it looks exactly like an old WHO Partograph. It is a A4 size paper with so many sections. Here there are actually 7 sections, and there are columns, there are rows, and there are things to enter. I am going to explain them. So what are these 7 sections? First is identification, second is supportive care, third is Care of the baby, I'm running because I've already told this yesterday. And care of the woman and labor progress. 6 is medications and 7 is shared decision making. This is the new one, as I said. Number 2 and number 7 are the new ones. These sections contain a list of labor observations. This is the closer look of the same labor care guide. As you can see now more closely, the rows are there to make the different observations, and the columns are there to note what time these things happen. And this first column is the alert column, and these talk about the timeline. So 5, 6, 7, these are the sections. As you can see here, we are talking about contractions, cervical dilatation, descent, and etc. medication. So section 1, I've already explained yesterday, so I can again run through. It is nothing but just the identification, name of the patient, parity index, labor onset time, active labor diagnosis time, ruptured membranes or not, and what are the risk factors. And this should be started after 5 centimeters. Of course, you make an entry when she comes into labor room, but then start plotting after 5 centimeters. So here is the example which I have taken directly from WHO Labor Care Guide. Mary Jane Williams is the name of the person, and every example we are going to follow her up only. So she's a gravida 2, but she had a history of stillbirth in the past, and now she has got anemia as well, and she ruptured the membranes at 5 o'clock in the morning on 6th July 2020. So section 2 to 7, as I said yesterday, we have to have a general idea before we go into each section. It contained a list of labor observations, which you saw on the left-hand side of the labor care guide. Should be recorded for all sections soon after the woman is admitted in the labor ward, but you have to do observations throughout. Yesterday, somebody asked me how often we check. I'm going to come to that. Let me keep it a suspense. The remainder of LCG is then completed following subsequent assessments throughout the labor. And monitoring to action to ensure the systematic and consistent application of LCG, health providers are encouraged to use following approach, that is assess, record, check every now and then plan. If at all you have to refer the patient. So this is a very important thing to understand. Let me explain this properly again, because many people ask me to explain this. If you understand this particular slide, then rest of it is very, very easy. So this is the topmost thing where you can see this whole thing is like a timeline, which is 12 hours, because they have given 12 hours for the first stage. From 5 centimeters, they have given 12 hours. So as you can see here, the horizontal time axis, which is boxed in the blue box, and that is to just note the time. The upper row, you are writing the actual time, and the lower row tells this is at the end of 1 hour, at the end of 2 hours, at the end of 3 hours, 4 hours, and like that. And then you have an alert column here, and they have written what is the alert threshold. I'm going to explain that. Okay, so that is in the vertical column. Based on that same thing, you are going to enter. And as I said, this has got a second stage monitoring as well, and they have given 3 hours maximum for the primary gravida. Okay, so this is how, as I said, patient came at 6:30, and at the end of 1 hour, it is 7:30. At the end of 2 hours, it is 8:30. 3 hours, it's 9:30. And she entered the second stage hardly within 6 hours of 5 centimeters, and that is at 12:45. So it's quite okay. She didn't take 12 hours. So this I've already explained. And now, yesterday I was explaining supportive care and the time went off. So let me start now. The section 2 is the actual labor monitoring and documentation, apart from identification. It is talking about supportive care. What is that? Whether there was a companion or not during her labor. If the companion was there, you write Y, S. And if it was not there, you write N, that is no. And if the woman declined a companion, sometimes companions can be nuisance, especially in our setup. We initially allowed the husband and all that. Later, we realized it is very difficult sometimes to handle the relatives. Of course, mother and mother-in-law are okay. They will understand, but the husband sometimes won't understand. They'll think that we are doing something wrong. So anyway, if it is there, you write yes. If it is not there, you write N. Now, what is the alert here? Alert here is if it is N. Okay, if you write N anytime in the timeline, that is the alert, because WHO expects a companion to be there. At least the companion can be a nurse also from the hospital or a nursing home, a doctor. It can be anybody. It need not be always relative. Then pain relief. If it is given, yes. If it is not given, no. And if the woman declined for whatever reason, it is D. And the alert is if you write N. Then comes the oral fluid. If she has taken oral fluid, yes, that is Y. No means N. D means decline. What is the alert? If she has not taken any fluid, because you all know she drains a lot. Labor, the name comes because she's really laboring. She's exhausting herself. She will be dehydrated. So enough hydration should be there. Oral fluids. It is better to avoid IV fluids, unnecessary IV fluids, because that will overload the system, especially if she is heart disease patient, she is preeclampsia patient. It can be detrimental. So always encourage oral fluids. It can be anything. Simple water also is okay. And then posture. If she is in supine posture, it is dangerous. If she's mobile, it is better, or if she's in the left lying position, it is better. So supine is alert. I keep on telling this to all my PGs everywhere, that whenever I see a patient in the labor room lying on the supine position, I actually tell the PG, you have not informed her that she should be lying down in the left lateral position. So let us see how to plot this. As you can see here, the first column, they have already given, it is already there in the labor care guide chart. So N means alert, N means alert, N means alert, SP is an alert, supine position. So here, these are all circled red to indicate that these are alerts. Now, as you can see here, now the same Mary Jane Williams, she came at 6 o'clock. When she came at 6 o'clock, as you can see here, I hope you can see very clearly, there was no companion. So we have written N, and I have circled that it's an alert. So make sure that there is somebody with her. Pain relief, she has not taken. That's not good. So N, alert. Oral fluid, luckily she has taken, so it is Y, which is okay, good. And position or posture, she is mobile. That's fine, because she is not having any other problems. So, but at 7 o'clock, as you can see here, after 1 hour, then companion came. So it is Y, that's good. Pain relief she has taken, Y, that is good. This is after 5 centimeters. Remember, don't intervene unnecessarily before 5 centimeters. No need of any actually augmentation or analgesics and things like that. Sometimes the labor can stop. So here, definitely you have to give pain relief. And oral fluids, yes, she has been taking. And now she has gone to supine position. We have written SP, and that's an alert. So I have circled it as red. I hope it's very clear, very simple, very easy. It can't be simpler than this. Now, let's go to, after these two boxes, let's go to the third section. Third section is talking about the baby. This was already there in the previous Partograph. Here it is little more clear, and it is beautifully alerted to us. So first things first, we talk about fetal heart rate. All of us know the normal heart rate, 110 to 160, and less than that is bradycardia, more than that is tachycardia, and anything more than 180 is super tachycardia, supraventricular, fibrillation, almost like, and it is anything less than 100 is very bad. So, but we are talking about deceleration. If there are no decelerations, you write N. See, N is not always an alert. Every time you have to remember this. N here means no deceleration, okay? In the previous one, no, N is bad, but here N is not bad. E means early deceleration. All of us know early deceleration is due to head compression, and it will change after the position. L is late deceleration, and we know that late deceleration is the worst thing that can happen, especially if it is lasting for more than 3 minutes, and it is crime to wait up to 5 minutes. V for variable. So can anybody guess here? It's an easy guess. What is the alert here? Alert is L. Okay. N is not always the alert. Okay. In previous section, N was an alert, whereas here L is the alert. Okay. Late deceleration is the alert. Then you talk about amniotic fluid. It was there in the previous partogram. Here they have clubbed it with the baby. That's a better thing actually. I means intact membranes. Good. C means membranes ruptured and clear fluid. Also good. M is meconium stained lacquer, and you can put it as 1+, 2+, 3+, which is thin meconium, moderately thick meconium, and the thick meconium represents non-significant, medium, and thick meconium respectively. B is for blood stain. So which can be alert here? M is an alert. B is also an alert because there can be intrapartum abruption, which is not good. It could also mean a silent rupture or a rupture of uterus, which is also not good. So M and B are the alerts. If you write M, it's an alert. B is an alert. Is it difficult? It's very easy, isn't it? It's not at all difficult. We know all these things. That's the beauty of it. That's the beauty of WHO. They simplify it. They simplify it because it has to be used in a sub-Saharan Africa. It has to be used in a remote village. It has to be used in a primary care center by a nurse, by just a simple birth attendant. So they have made it so simple. And now, other things about the baby. Fetal position is occipito anterior. Of course, all of you know how to make out occipito anterior. You can do an abdominal examination itself. If the fetal heart rate is more towards the center, it is occipito anterior, or occipito posterior. If it is more towards the flank, it is occipito posterior. And any occipito transverse. Transverse, of course, on the abdominal examination or auscultation, it is more in the flanks, but on per vaginal examination, you can nicely make out the sagittal suture in the transverse position. And of course, occipito posterior, in PV, you can easily make out the anterior fontanelle. So both by abdominal examination, auscultation, and a per vaginal examination, you can make out this. And what is the alert here? No prize for guessing. Posterior and transverse are bad. PT is the alert. And now comes the caput. Caput, 0 is none, 1+, 2+, 3+. 3+ is inseparable or molding. And as far as caput is concerned, it is not going to go away that easily, and head is very high. So of course, 3+ is bad. Now I talk about the molding, which I was talking about. I was a little premature in talking about that. 0 is none, 1+ is sutures just approached, and 2 is they are overlapping, but it can be on pressing. It will go back. And whereas 3+ is they are overlapping so much, even after pressing, they won't go back. So this is bad. 3+ is bad. So very clear indications or referral points for us. So as you can see here, how it looks I'm just zooming all the sections, how it looks in the actual partograph. So it looks like this. Baby is the section, and here they have clearly written baseline heart rate less than 110 and more than 160 is bad. Deceleration, if it is L, is bad. Alerts and amniotic fluid, M is bad, that to M, 3+ is bad, B is bad. Fetal position, posterior and transverse is bad. Caput, 3+ is bad. Molding, 3+ is bad. Let's look at all of these things in our Mary Jane Williams. So at 6 o'clock, her fetal position was posterior. Do you think it will change? Yes, it can change subsequently later, isn't it? In labor, it will change. 90% of them will become anterior. So that is the situation at 6 o'clock. And at 7 o'clock, they have not done a PV, so they have not probably written anything. How often to do PV? Should I break the suspense? There is no change. It's the same as old teaching. You do per vaginal examination once in 4 hours only, unless there is a compelling indication to do it earlier. So there is no mention about the fetal position here or caput or molding because they have not done a PV. But FHR, they have entered. Baseline is okay. No decelerations, and there was a variable deceleration. They changed the position, which is later become N. So N is no deceleration here, so no problem. There is no red circle here at all. Is this very clear? If it is very clear, I'll move on to section 4. Section 4 is care of the woman. Okay, so care of the woman. And here it is urine we are talking about. P is for non-proteinuria and P is for trace, P1 plus, 2 plus, and 3 plus. No prizes for guessing. P2 plus onwards is an alert. Of course, P3 plus is automatically an alert. Acetone. Again, acetone, A2 plus onwards is an alert. Okay, so it is automatically 3 plus, 4 plus is definitely an alert. Now, how do you see that? In a woman, pulse less than 60, more than 120 is an alert. Systolic BP less than 80 and more than 140 is an alert. Systolic blood pressure. Diastolic, anything more than 90 is an alert. Temperature less than 35, more than 37.5 is an alert. And as far as urine is concerned, P2 plus, A2 plus, protein and acetone. So all parameters of the mother are here: pulse, BP, which is both systolic and diastolic, and temperature. And you see what is the alert here. These are the alerts. Anything less than 60, more than 120, anything less than 80 and more than 140, diastolic more than 90, temperature less than 35, more than 37.5, and urine containing protein 2 plus and acetone 2 plus. So what happened in Mary Jane? So when she came, everything was fine. Pulse was 88, BP was systolic 120, diastolic 80, temperature was 36.5, urine nothing. Now, after 4 hours, at 10 o'clock, her pulse was okay, 96, systolic BP was 128, not bad, diastolic was 84, not bad, and temperature is 36.9, okay, and urine still good. So this is how you write. Now, so far, let us summarize what all we have checked. We have checked the identification we have done, then we have gone for the supportive care. At the end of 4 hours, can you see the supportive care? Still there is, the companion went off, maybe he was there for these 3 hours, but then he went off or she went off. Pain relief, she has taken earlier, now she has not taken. Oral fluids, she declined at 9 o'clock, but she took all other times. And she has gone back to supine position, which is not good. That's why you alert. See, that is the beauty of labor care guide or a Partograph. At a glance, you can make out when you circle red, these are the alerts for you, and you have to immediately take action. So that's the beauty of it. An intern or a PG or anybody should be able to do this, even the nurse. Baby, as far as the baby is concerned, from posterior position, it has come to transverse position, which is okay. And amniotic fluid is just 1 plus meconium, which is thin meconium, which is all right as long as the fetal heart rate is good, because there is no problem with the fetal heart rate. There are no decelerations at all. N, V, N is okay. Only L is bad. And baseline heart rate is 133. That's why meconium has no significance at all, as you know that. Caput, just 1 plus maybe, and here also 1 plus molding, that's also okay. And pulse of mother is still holding nicely, no problem at all. So this is the summary of section 1 to 4. Now comes the major problem or the major deviation, labor progress. This is a very important part of the whole labor care guide. Earlier, we used to call it the alert line, action line area. Now here, it is not so. Here they are talking separately about cervical dilatation, no alert line, no action line, and they are talking also about the descent of the head. And each centimeter has been given time. I'm going to zoom in and explain properly. And this is the highly controversial area. When I gave this talk in Hyderabad, after the talk, many people said, Murli, do you believe in this seriously? So that's why I have in this particular talk, I have put some question marks, but then I will explain why I may agree, if I don't believe totally, but I may agree with this. So alert values for contractions first. It was there in the earlier Partograph also. Here also we have contractions, but it is more clear. There it was shading, dots, this and that. It was confusing. But here it is very clear cut. For 10 minutes, if it is less than 2 contractions or more than 5 contractions, it's an alert. It's bad. That's why I put it in red. More than 5 contractions or continuous contractions suggests obstructed labor or hyperstimulation. Maybe you have, if you are using oxytocin, you have to immediately stop. And if you think that she's going for obstruction, then you have to call a senior. And maybe if you see a bandage string, probably that's the time you have to take a first section to save the mother and the baby and yourself. Duration of the contractions. If it is less than 20 seconds, not good. If it is more than 60 seconds, bad. So beautifully given. How many contractions, how long it should be, everything is beautifully given. So if it is less than 20 means inefficient and or short, inadequate uterine activity, and that will not drive the head down or rotation and things like that. What are the alert values for cervical dilation? This is a very, 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 very important slide. Look at this slide carefully. Now, first stage, we are talking about an active first stage, that is after 5 centimeters. If a lady has 5 centimeters for more than 6 hours, that is cervical dilatation remains at 5 centimeters for more than 6 hours, that's an alert. Now, this is the big question. You may ask me, sir, will you allow her to be in 5 centimeters for 6 hours? I may not, but then Zhang's Partograph said the active phase starts at 6 centimeters, if you remember. Okay, so now, according to Zhang, up to 6 centimeters is latent phase only, and latent phase is always indefinite. So that way, I said, I may accept this. After all, she is at 5 centimeters level, and she may take up to, say, we have been given 12 hours for active first stage, remember. So in that, if she has taken 6 hours, it's okay. But if she takes more than 6 hours, it is not okay. Okay. Now, let's say she has progressed to 6 centimeters, but she remains there for 5 hours. This also is very difficult to accept for us. We have to accept with a pinch of salt. Don't shout at me. This is labor care guide by WHO. Okay. And 7 centimeters she has gone to, but she remains 7 centimeters for 3 hours. You can wait for 3 hours after 7 centimeters, but then if it is more than 3 hours, something is wrong. So what I'm trying to say is that, of course, all the 3 actually ask for double, exclamatory marks and double questions, but I remove them. I remove them because given the understanding, it is all evidence-based according to WHO, LCG, that they have seen that women vary from one another. They can have up to 12 hours sometimes. They can deliver within 6 hours. So if it is up to 12 hours, 5 centimeters can go on for 6 hours. 6 centimeters can go on for 5 hours. 7 centimeters can go on for 3 hours. That is the understanding or the meaning of this. I hope I have tried to clarify in my own way, but I'm not asking any one of you to just take it literally and just go by this. See, I'll tell you, you have to have the difference between the knowledge and wisdom. Knowledge, of course, is very important, but wisdom is more important. I can give another simple example. What is the difference between knowledge and wisdom? Knowledge is that tomato is a fruit, but the wisdom is you cannot make fruit salad with that, right? So this is the knowledge. You can have it in the back of your mind, but you can take your own decisions, okay? This has to be just not based on the time. Don't say, okay, I'll wait by the clock 6 hours. Don't do that. You have to look at the fetal heart rate. You have to look at the mother. You have to look at the contractions. You have to look at the caput. You have to look at the, the molding. You have to look at everything. Her exhaustion, her BP, her pulse, and the patients. Okay. So that is very, very important. I hope I'm clear about this. But anyway, this you have to know. She reaches 8 centimeters. Now you give her less and less time. Once she reaches 8 centimeters, you can't wait more than 2.5 hours. When she reaches 9 centimeters, you can't give her more than 2 hours. Okay, she has to deliver after that and progress and deliver after that. So now she has reached 10 centimeters, second stage, you can give her maximum of 3 hours. We used to say 2 hours. Again, here it is 3 hours. But don't blindly wait by the clock for 3 hours. That is not prudence. That is not prudent. Okay, so You have to be prudent. You have to monitor her closely, maybe in second stage more closely, and you have to see whether she's going in for a deep transverse arrest and things like that. Don't say she has gone for deep transverse arrest, but Dr. Murli said, based on WHO LCG 3 hours, I will not come anywhere near the labor room for 3 hours. Don't say that. That is foolish. Okay, this is the maximum time. That's all it means. And in multi, it is 2 hours. So there is no difference in the first stage for primary and multi, but there is a difference in second stage for primary and multi. I hope you have understood that and observed that. Alert for descent. It was not very clearly defined in old Partograph. Here also, it is not very clear. There are no reference thresholds for this observation, which will vary on each individual case. Sometimes we have seen this. Till 10 centimeters, there is no much descent happening, but after that, suddenly it descends. But some people, some women actually in second stage, they don't descend properly, they don't have rotation properly, but last few minutes, everything will happen suddenly. So we have seen all this. That's why there is no clear reference in LCG. So let me look at this cervix and descent. So it is beautifully written here, 10 hours. You don't wait anymore. That is, she has already gone into second stage. Contraction-wise, alerts are if it is less than 2, more than 5, less than 20 seconds, more than 60 seconds. And you can see here that 9 centimeters, you can't wait more than 2 hours, 8 centimeters, not more than 2.5 hours, 7 centimeters, not more than 3 hours, 6 centimeters, not more than 5 hours, and 5 centimeters, not more than 6 hours. And for descent, there's nothing is given. In active stage, plot X to record cervical dilatation. Alert triggered when lag time for current cervical dilatation is exceeded with no progress. And of course, this is how we plot it. The second stage, insert P to indicate when pushing begins. Okay, so let us go back to our patient. Now, let's say at 6 o'clock, she was 5 centimeters. I can't wait more than 6 hours. It is already written in the LCG. Now, after 4 hours, I do a PV and she has already gone to 8 hours, which is okay, right? And then she is remaining with that, let's say she is, let's say in the other case, if she has remained 5 centimeters for 6 hours, that's why I put a mark. This is another case, okay? So the previous one was okay. If she progressed like this, it is okay. But if she didn't progress, if she remained 5 centimeters, even after 6 hours, see here from 6 o'clock to 12 o'clock, this is 6 hours. This is not okay. That's why I have circled. Okay. And now let's go back. She reaches 10 centimeters in 5 hours. 6 o'clock she came. By 1 o'clock, she's 10 centimeters. Perfect. She's perfect. Okay. So descent also, you just write it. This is okay. There are no reference points anyway. Now, section 6 is very easy, simple. Medication. If you have given anything, write it. If you are not given anything, don't write it. Oxytocin, N or yes. Medications, N means no, if is yes. IV fluids, yes or no. That's all. Okay, there is nothing much alert as such. So you have written whether anything is given or not. I can just skip this. Now, 7 is the shared decision, that is assessment and the plan. So you can write it here. What was the assessment? What was the plan? Whether to refer her, whether to wait for some more time in the same place, and you have to put the initials. So that is what is all about. So what is the assessments? Record overall assessment and any additional findings not previously documented but important for labor monitoring. And the plan can be each time a clinical assessment of the woman's and baby's well-being is completed, record the plan based on the shared decision. For example, continuation of routine monitoring, prescription of diagnostic tests, some more tests you want to do, augmentation of labor with oxytocin infusion after ARM, procedures like ARM, assisted birth with vacuum forceps or LCS, whatever it could be. Take into consideration that women should be involved in discussions and be allowed to make informed decisions. This is very, very important. Discuss with her husband, patient party, or whatever it is. When you discuss and explain to them, it is much easier than you take your own decisions. So this is how the shared decision is plotted. Now I come to the last leg of my talk. I'll try to finish it today. WHO recommendations. This is just like a summary. In first stage, recommended means green, auscultation every 15 minutes. no change. PV intervals every 4 hours, no change. Epidural analgesia can be given, parental opioids can be given, relaxation and manual techniques for pain relief is okay. Some people, massage their back, that's fine. Maternal mobility is allowed if she has no problems. Oral fluids should be given. Not recommended are for healthy and spontaneous onset labors, routine clinical pelvimetry. I have put a question mark because I took a big class on pelvimetry. I believe in that. But anyway, WHO says if she's a healthy woman and if she has no problems, she's okay. Routine admission CTG, again, they have said not required, but I put a question mark. It is better to do always, especially if you have induced. Perineal pubic shaving is not required, but if it is coming in the way, maybe you can just clip it. Enema for reducing the use of labor augmentation is not required, but if you think that she's going to soil in the second stage, you may give her an enema. Routine vaginal cleansing is not required, but if it is, if you see any discharge, especially pus and other things, maybe you can clean it. Interventions for CD less than 1 cm/hour in active stage is not at all required. And more things not required. Continuous CTG not required, they have written, but I put a question mark. In high risk, you may need it. IV fluids to shorten the labor is not required, but IV fluids, if she's not taking oral fluids, may be required. Active management of labor, according to WHO, is not required. Routine or early amniotomy plus oxytocin not required. Oxytocin for women with epidural analgesia is also not required. Antispasmodic agents, epidocin we used to give, not required. What is recommended in second stage? Auscultation every 5 minutes, same as before. Birth position can be anything, upright. I remember once somebody told me that a very, very VIP stood and delivered, but you have to catch the baby properly. Pushing is encouraged, but they should follow their own urge. Don't say, biki, 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 biki. Don't say that. She can push at her own urge. Preventing perineal tear, you have to give us support. Not recommended are routine or liberal episiotomy, application of fundal pressure. It was a big controversy once in Manipal, but WHO doesn't recommend it. Third stage, uterotonics for prevention is recommended. This is standard 10 units of oxytocin, and then argometrin, if you don't have it, can be given. And of course, misoprostol 600 mg in the primary settings. Delayed clamping is always advised by everybody. And controlled contraction, of course, is the method. But sustained massage is not required. Thank you very much. I could finish it, though I had to rush a little bit in the last few slides, but that all was known to us. Basically, what they're saying is avoid fundal pressure and avoid continuous massaging if you have already given uterotonics. This is the main difference. And in second stage, of course, the difference is don't force her to push. Let her use her own urge to push. So that is always better. Of course, you have to closely monitor her every 5 minutes in the second stage. And the other things in the first stage they said is that there is no need of continuous monitoring. Of course, it depends upon the case and depends upon sometimes your center. You can go for continuous monitoring, nothing wrong in that actually. But if you don't have intermittent auscultation is as good. So I hope I have made it simple for you. And I will send a synopsis tomorrow of the part 2, like I sent the synopsis of part 1 today. And I hope to upload this on YouTube for the benefit of those who could not.